Good afternoon, ladies and gentlemen, or at least this afternoon in Houston, Texas. I'm pleased to be here today to talk to you about lowering blood culture contamination rates using an evidence-based medicine approach. And one of the things that I noticed at the recent American Society for Microbiology meeting in Boston about less than a week ago is that everything now seems to be outcome studies or evidence-based medicine, and probably rightly so. So what we're going to look at actually here is a systematic review approach that was developed by the Centers for Disease Control and Prevention in collaboration with the American Society for Microbiology. And basically, we've used this now not only on this particular systematic review that we're going to talk about today, but in several that the American Society for Microbiology is taking the lead on in collaboration with the Centers for Disease Control. Which brings me to an introduction for myself. I'm Alice Weissfeld, and I'm the laboratory director at Microbiology Specialists Incorporated, and I'm talking to you today as the chair of the ASM's Evidence-Based Medicine Committee, which is part of the ASM Professional Practice Committee. And I have a history, somewhat of a history in writing guidelines because in the late 70s, I was on the editorial board of ASM's QMETech. We had a lot different approach to how we wrote guidelines in those days, because what we used to do was actually appoint people and say, okay, you're an expert, you're an expert, you're an expert, and then write the guidelines. And I've since realized, once seeing the CDC actual, how the actual guidelines are written in this systematic way, how silly that seems in retrospect. But I guess in those days, it was the best that we had. So I thought that I would start out by just giving you some information about the CDC evidence-based medicine approach, and then go into how it has applied in this issue of blood culture contamination. The CDC method is also known as the A6 cycle, and you can see why there are 6 A's, because each of the different steps starts with an A. So in looking at a quality gap or a policy problem, the first thing we do is we ask a question. And the question in this particular case is going to involve how can we reduce the blood culture contamination that we usually see. The next A, the second A, A2, is to acquire information. I'm going to show you how we do that, but we do that with the help of a professional medical librarian. The third step, A3, is to appraise the evidence. And this is done by a very torturous but very transparent method in which everybody uses the same form to actually assess papers. And 2 people have to become experts on each of the papers that they're assigned. If they don't agree in their assessment, it's sent to a third. The next step is A4, analyze, and what the people are doing in this step is basically sending data that has been rated either good or fair to a meta-statistician who does a meta-analysis and creates forest plots, which you'll see later, that actually show you whether what you're looking at as a method to improve patient outcomes is actually better, worse, or no different than the method that you have looked at before. A5 is an apply step. A6 is an assess step. We're not going to talk about those today. We're just going to get to the analyze step. But the CDC has issued like cooperative agreements, and ASM was awarded one in which we're actually seeing if we have a clear picture of what the best way to do things are laboratorians actually doing that? And if they're not, why aren't they? And those are the apply and assess techniques, which will not be the subject of today's talk. Okay, so again, the first thing that you look for in looking at a laboratory medicine best practices systematic review question is what is the problem, or what are you looking at? And the answer here for the question is, what practices are effective for reducing blood culture contamination? And you might have also heard outcome studies called PICO studies. And you can see that I've highlighted the P, I, C, and O, and the P in PICO stands for the population. So in this case, we could have been doing studies on how many children have had blood cultures collected and how many are contaminated. But in this particular one, our question is, of all patients who have had blood cultures collected at our institution, how many of them actually have a better outcome because of changes that were made? For intervention versus what the comparator or the comparison is, we studied venipuncture versus IV catheter draw, and that's from an indwelling catheter that people have placed in some cases. Phlebotomy teams versus non-phlebotomist staff collections, and this would be, for example, having nursing or some other people other than a team of phlebotomists collect, house staff, that kind of thing. And then the third thing was to look at, do pre-packaged prep kits that have the betadine and the alcohol and the syringe and everything included make any difference or result in a better outcome than if you have just the individual components in a tray, so that you have no actual prep kit, but the components individually. And then our outcome in this particular study is a reduced blood culture contamination rate. Okay, the first thing that you do after defining your question and looking at the PICO information is to actually prepare an analytical framework. And if you read all of the different systematic reviews that have been done by the CDC method, you're going to see this same analytical framework in every one of these. And actually, the seminal article, for those of you who may know Rob Christensen, who is a former president of AACC, the Chemistry Association, he wrote the seminal article with CDC about how you do an A6 systematic review. So the first thing is to address what is the quality problem, which is essentially restating what we saw in the last slide. And here, the quality problem is going to look at contamination of blood cultures, produces false positive test results. There is not really a bloodstream infection, and what we're worried about as far as patient outcomes is this can lead to adverse patient outcomes and wasted healthcare resources, because those patients are often put on antimicrobials that they don't need, and have increased length of stay and other issues. So that is our quality problem. The preventability and improvement part of it is, can we lower our blood culture contamination rate? And all microbiology labs monitor their blood culture contamination rate as one of the things that you do for quality assurance. And you can see here that in the literature, the range of contamination that people report is as low as 0.6% and as high as 12.5%. And in this particular guideline, they were looking for a target of 3%, because the American Society for Microbiology and the Clinical and Laboratory Standards Institute have said that 3% is a good place to be. Anything above that, you need to have an intervention to try to lower your rate. Anything below that is kudos for your institution. Now, the next part of the analytical framework is looking at what are the interventions and practices. We've already talked about that again in the C part of the PICO, and that is we're going to look at venipuncture, whether it is improved over using IV catheter collection. We're going to look at whether a phlebotomy team of dedicated staff is better than just using other either house staff or nursing personnel or other people who are trained to draw blood. And we're going to look at whether prepackaged prep kits are better than just using individual components. And we like to look at within this some of the harms, and the harms could be if you're like contaminating the blood, a needle stick injury risk, or a patient collection site infection when they didn't need to, like have it, because they're usually redrawn once they come up with a positive, and they may not have had to have that second collection. We look at intermediate outcomes, and then over to the right, healthcare outcomes. And so an intermediate outcome is to look at blood culture contamination rates, additional testing, as we just discussed, which may not be necessary, any follow-up associated with a reevaluation because a physician comes back, the patient has no fever, no other signs of sepsis, but they draw them again, and then any costs associated with either an unnecessary draw or an unnecessary antimicrobial therapy. And then for the healthcare outcomes, there are obviously going to be diagnostic and treatment delays, because there's always the question of whether during that draw you got a contaminated draw and you missed, because of low numbers, the actual organism causing sepsis. Diagnostic and treatment errors that occur because of that, unnecessary and increased hospital stays, unnecessary antibiotic use, hospital-acquired infection, and costs associated with the above. In essence, the effects of morbidity or mortality changes because of the fact that the blood culture was not collected properly. In order to do one of these A6 reviews, it's very organized in that the review coordinator has the primary responsibility for actually conducting the review. And the review coordinator is usually picked because they are familiar with good scientific method. They have a relationship or are willing to develop a relationship with a medical librarian, and they're willing to lead what is, in some cases, a very intense discussion in order to get to what are the best practices. So the review coordinator appoints a review team. This includes, because we work with the CDC, a CDC liaison, an ASM liaison, a lead technical person, and then the review coordinator themselves. There's also an expert panel who have the scientific and technical authority from the membership to make decisions on behalf of the membership. And these people either are selected from experts in the field or from people who have volunteered to do this. The second thing the review coordinator does is actually devise a literature search strategy with the medical librarian. So in looking at the analytical framework that we just saw, one of the things that happens is that you develop keywords. And for those of you who have written manuscripts, for years, we actually have put down keywords that the authors think will help to identify those particular papers when somebody is searching. So for example, this could be phlebotomy teams, can be a search word or whatever. And this is very important because you want to make sure that you've gotten all of the literature. Then the review coordinator gets the information from the medical librarian, reviews abstracts, and what we call assembles pertinent literature, and assesses, is this something that we have enough information for, and are these pertinent to the questions that we're asking? Again, in this case, venipuncture versus a line draw, whether we should use prepackaged kits versus just individual components, etc. The review coordinator will assign 2 independent reviewers from this expert panel for each reference that they feel is applicable to the subject matter. These people assist with the data abstractions, and then when the data abstractions are sent back, the review coordinator organizes and codes the literature following the CDC A6 method. The review coordinator also compiles the evidence summaries. If you've looked at these types of papers, there are a body of evidence tables for each question, and those are prepared by the review coordinator in concert with the biostatistician. They coordinate the evaluation of unpublished data in the review process. And one of the first ones of these that the American Society for Microbiology did by themselves was on bloodstream infections, and whether some of the rapid PCR assays resulted in better patient outcomes because of the fact that rapid testing was performed, albeit that the rapid testing may have added cost to the actual laboratory test. In the information that was available at the time that ASM did this, we were not able to make a recommendation either for or against whether that was important. But what we are doing is we're actually, in that paper, giving people a way to be able to upload data that can also be abstracted and reviewed in the new review process when we look at this again in about a year. And a lot of people have data, but they haven't been able to publish it, or it's been rejected, or for whatever reason it's not in the published literature. So one of the things I really like about the CDC method is that we can look at unpublished data, and either people can say, I want my data to go into the mix and don't say who I am, or they can say, like, please let people know that this hospital contributed the information that has been used in this. And this literature, you might hear, if you're interested in this, is now known as the gray literature, because it's out there. People know from their own QA studies what it is, but it just hasn't been published. Finally, the review coordinator evaluates the evidence summaries and evidence tables and produces draft recommendations. And then the CDC has an LMBP work group, which are composed of various laboratorians who actually take a look at this, question the results, and if everything is good, the data is then published with those recommendations. Okay, so let's look at specifically what happened in the blood culture contamination search. We look at 3 databases usually: PubMed, which many of you are familiar with, I'm sure, and then Embase and Cinel. And these, in looking at this, we look at English language articles from 1995 to 2012 with regard to human subjects. And the medical librarian is a key in, like working with the review coordinator in finding those articles. There's also hand searching of bibliographies from relevant information sources. One of the things that we discovered in one of our guidelines that we're working on urinary tract transport and collection was that some papers that we were reading had references that were not in our bibliography. And we should be able to say at the end of the day that we've captured everything that's relevant to the information source. So in order to do that, during this period, we look very carefully at the literature to see if there are any things that have not been found by the librarian for whatever reason. This time is also when we solicit any unpublished quality improvement studies so that we can add these in. And for the blood culture contamination, there have been 3 or 4 institutions that have since submitted blood culture contamination data from their own institutions. Okay, for the screening criteria for initial appraisal of evidence, the first thing that you want to do is exclude things that obviously are not applicable. In some cases, you get over 2,000 articles, and even with a large number of people on the expert panel, it's a daunting task to try to look at 2,000 articles. So you first, as I said on another slide, go through, and the review coordinator is looking at, is this a situation where this is even applicable? And the way you do that is in this paper there a practice that's relevant to the topic question that's being assessed? So if you're looking at whether blood should be drawn using a phlebotomy team or not, then like they're talking about in the paper antimicrobial therapy at the time of blood culture positivity. Obviously, that's not going to be a paper that you're going to review because it's not in the practice that you're looking at. Also, the practice may not have been sufficiently described in the paper that you're looking at, or the description is inconsistent with the evidence review practice definition that we developed in the framework. So this is pretty rigid so that we can actually be sure that we're looking at the things that we want to know, that we decided we wanted to know before everything started. And then we obviously don't use anything that is either commentary or opinion, letters to the editor, unless they contain additional information that's considered important. Inclusion criteria is just the opposite. If something is to be included because it's talking about something that we want to look at, then we do the full text and abstraction by 2 members of the expert panel. And basically, what you do in this case is you make sure that there's at least one aspect of the topic addressed in that manuscript that you're reviewing, that it's in use and available for adoption, that it's reproducible in other comparable settings. So if one person tells you that they use a phlebotomy team and everybody else says that they don't in the paper, it's not necessarily going to be helpful for phlebotomy teams. But this is part of what's addressed as you look for the information. You need to make sure that you're addressing a defined population of patients and that it has potential impact on the outcome related to one of the following healthcare quality aims. And the government has spent a lot of money recently looking at improving the delivery of healthcare by looking at these aims. So these are things that you potentially are going to hear about when you're talking to your colleagues in healthcare, and those are effectiveness, efficiency, patient-centeredness, which is at the heart of everything that we're trying to do in the laboratory, safety, timeliness, and equity. So you want to make sure that what you're doing is addressing some of these issues as well. So here's the flow diagram, and again, this is included in all systematic reviews for the blood culture contamination. And you can see how this is whittled down. So there were over 450 records that were identified from various databases. Of these databases, there are always duplicates that you get because the topic is pulled from different keywords. So 348 were excluded. And then if you look up on the top, 15 additional records were identified that were not identified during the actual review by the librarian, 2 that were unpublished, and 13 from hand searches. So basically 108 records finally were screened for practice effectiveness. 87 were excluded because inclusion criteria were not met. They were left with 21 full text studies to actually look at for the expert panel. 4 were excluded in the end because of study quality criteria not being met. And so if you look at the actual systematic review, the manuscript, out of 456 studies, 15 more that were found by looking for additional records, only 17 studies were included in the analysis. So there's a lot of culling out that happens to get down to just the questions. And it turns out that of those 17 studies, 9 were on venipuncture versus catheterization, using a catheter to actually draw the blood. 5 were on phlebotomy teams and whether they were better, and 4 were on pre-packaged prep kits. So there aren't a terribly high number of actual papers that you're left with. And one of the things that has held up is that the CDC says that if there are at least 3 that actually work, you can actually make some kind of decision as long as the statistician says that it meets the criteria for meta-analysis. Okay, so the expert panel who's looking at all of these 21 has to reach consensus on the topic area and basically on not only the quality but the effect size. So if the paper is discussing what happens to 8 people, the effect size is pretty low. You'd like to be in the hundreds and perhaps even higher than that, in the thousands, to know that there were enough people and enough tests that were reviewed to actually make good decisions. You have to evaluate the individual practices' overall strength of evidence and effect size consistency. So it's not only looking at the effect size in one manuscript, but in several manuscripts that focus on the same body of evidence. You need to develop final draft practices, evidence summaries, and draft recommendations. And for the quality ratings part of it, they come up to be either good, fair, or poor. And for effect size ratings, they're either substantial, moderate, or minimal, or none, because they're talking about like 1 or 2 patients. You provide feedback to the concerning the limitations of the evidence review process in the manuscript and possible improvements for people who want to look at the situation in their own institutions and use these as quality assurance guidelines. And again, for people who do that, the CDC loves for them to upload their data as gray literature, so we can either confirm or deny the reports that we have written the first time. Okay, so what are some of the lessons learned so far? First of all, there is information commonly missing or inadequate in laboratory medicine papers, and let me just tell you a few of those that make it hard to actually use all of the literature. One is a sample description. The study population being analyzed is incomplete, or the setting is not really distinctive, and you can just generalize. So maybe it's all about children, which adds a bias. Maybe it's all about males, which adds a bias. Sometimes they don't even say, if you're looking at the papers, what the study population is. They just say we studied people who came into the emergency department, and you really can't say, were those children, were those adults, were those males, were those females, and did they come in with heart attacks, did they come in with infections, that kind of thing. So if you're thinking of writing a paper for this, these are the kind of things you should include. For sample size, which is the number of patients that you studied or the number of tests or the total number of samples, sometimes people give inadequate decisions, so we can't do what I call a robust analysis of the practice. Data collection method could be also inadequately described. So some people will say this was done for the first 3 months of the year. Some people will say we just did this and there is no seasonality or any indication of when these specimens were collected, and they could not be really stratified other than as random specimens that came in one after the other. The time period, the project, and the intervention start and end dates are usually missing in some of the earlier papers, but included in some of the later papers. And then sometimes the intervention is inadequately described to allow it to be replicated. So if you're looking at something and somebody tells you, I think that this is a lot better technique, and you have not described the technique, you can't even tell what the intervention is. The outcome measure could be inadequately identified. And remember, everything is patient-centered. One of the nice things about doing these things is that we look at the patient first and foremost to decide like what best practice is. A lot of people have not applied statistical methods, and like they appoint each other, as we used to do at the Cumitech, to be experts, and then they have not like applied statistical methods to see if things hold up to a really intense analysis. And then sometimes the cause and effect relationship of intervention and results cannot be clearly proven. So this is where, again, the meta-analyst comes in, because the one we work with, for example, at the American Society for Microbiology, is someone who he's an epidemiologist. He has a master's in statistics and a bachelor's degree in microbiology, and he understands not only the microbiology part of it, but he understands it from an epidemiologic and population-based method. Okay, so here is the abstraction form. And, like when we're training people at ASM who want to do new outcome measures, by this method, we use the information that you see here in this form. And it makes it looks, and I guess my mind must be, like fairly rigid in this way, because I like the fact that you have to all look for the same information, and it has to be there in order for something to be included. So the first thing is just generalized demographic information. The final thing on that column, that first column, is funding. And none of these things really make a difference in actually looking at whether the paper has fundamentally good information. It's just, who supported it, if somebody supported it, who the authors were, and where they were from. In the second column, actually, these are the first points that somebody makes. And these are given 3 points, and basically it looks at, is there study bias, and is there potential generalizability for not only this particular outcome study, but for other things that people are looking at. And so you look at the design of the study, the facility or setting, children's hospital, university-affiliated hospital, outpatient clinic. You look at the time period. You look at the population that was sampled. What is the comparator? Again, we know our comparators here: Venipuncture versus IV cath, phlebotomy team versus no phlebotomy team, and prepackaged kit versus no prepackaged kit. And then, is there any study bias? So, study bias is probably the most difficult thing to assess, and it really helps for the statistician to come in and help you with this, and like look at it on the back end almost, because basically it has to be something that is not just limited to one patient population, or if it is, that's okay, but then it has to fit in with what happened in that other age group in some other institution. And again, you get 3 points for that. The next thing that is assessed is the actual practice, and you do a description of that, the duration that the study lasted, the training, what staff and other resources you needed, and the cost of doing this. And these are ways that actually, especially cost, that people look at. What does it take to do these kind of outcome studies, and is it ultimately going to lower the cost of healthcare? And you get 2 points maximum for the practice. The next column is for outcome measurements, and you do a description and recording method for everything. And again, these can be by chart review. The description, like, is basically what was targeted in a particular study, which of the 3 outcomes did they look at, and you have a maximum there of 2 points as well. The final column is the results finding, and you look at what the type of finding was. Was this in the analytical phase? Was this in the pre-analytical phase? Was this in the post-analytical phase? And what is, obviously most of ours are in the pre-analytical phase in this particular question. So if we had something that was in the analytical phase, it really is not applicable. And you look at, do the people test for statistical significance, and were there any results or conclusion biases, that kind of thing. You get 3 points, so that at the end you add up the points from the 4 columns, and the first column where it says quality rating is an actual overall look at what happened. And pretty much what I could tell you is this is a lot of work to really read and analyze. Each paper is probably an hour to an hour and a half for each paper, and you do get faster over time, but you need to find the answers to all these questions while you're reading the paper. And the first time you usually read it for, just an overall view of what you would be doing, and then you really start to dig on subsequent occasions. Okay, so what it boils down to at the end of the day is actually a forest plot. And I don't know how many of you listening to this have ever seen a forest plot, but over at the right-hand side is a forest plot. And what the meta-analysis involves is actually seeing whether your comparator is actually better than your actual practice, so that you know that the intervention is working. So this one is it important to actually have a commercial prep kit? And if you look at the bottom where it says the number 1, when you look at forest plots, and this is the easiest way I could describe it to you, you look to see is actually meaning that the different papers that you see here, if they're on the line or close to the 1, which they are, there is no difference that could be notated. And there were 2 that actually were over, and you can see, the boxes over on the column for 2 and 8. But those really are the only 2. Most of the others are around the 1. So the decision in this paper was to say that there really is no difference. There's no need to buy a commercial prep kit, because there was no instance that could be seen, at least in the papers that were studied, on whether the actual kit was better or worse. And so if you know, the answer for this would be, if you feel like it's better for your hospital to buy that kit, then buy it. If you don't, and you go with individual components, that's probably fine too. It does not seem to have an effect on blood culture contamination. And the papers that were looked at are listed there. The ratings that they got are listed there. The statistical analysis is listed there. And then all the abstractions that you saw on the previous slide are presented for all those papers, so that you could actually look at these papers, do your own evaluation, and see everything that the people who did the abstractions have seen. Okay, so if you look at venipuncture versus catheter collection, there's a clear winner here. And you can see that practically every one of these papers that's shown on the left is showing that venipuncture, which you see on the bottom there, is definitely superior to catheter collection. And that catheter collection results in a lot more blood culture contamination. Okay, this is Phlebotomy Team, and again, these are the 5 papers that were evaluated for that. And basically, again, you can see that there's a clear, recommendation for using a phlebotomy team versus using just house staff, nursing, or people really who haven't been specifically trained in blood culture collection. Now, to sort of wrap this up and put this in a more global perspective, and that is, why is this even an important topic for an evidence-based medicine guideline? And so if you look in 1999 and 1991 in JAMA, you can see in this article called Contaminant Blood Cultures and Resource Utilization that if you have a contaminated blood culture, it results in an increased length of stay. And in this paper, they estimated 12.5 versus 8 days. It also results in increased charges for healthcare, 13,000 versus 8,700. It results in an increased pharmacy charges, 1,400 versus 798, and increased laboratory charges for the unnecessary workup, the identification, and the susceptibility of organisms that turn out not to be a contaminant. And these are $2,000 versus $1,400. Finally, in looking at strategies to improve cost effectiveness of blood cultures, one of the issues is false positive cultures are definitely higher when blood is drawn from indwelling catheters than when it is obtained by peripheral venipuncture. And so, like the people who are doing the draws have to deal with a number of things. And, does that mean that you can never draw from an indwelling catheter? No. I mean, I'm sure that there are situations where a stick for a patient who has had chemotherapy, long-term chemotherapy, is going to be much more difficult, and this is a better thing to do. But by and large, it's much better to actually, use the, do an actual peripheral venipuncture than do something else. So in doing that, so what do you look at then? Methods to reduce false positives. You can increase the time in antiseptic scrubbing. You can wait for the antiseptic to dry completely, which, by the way, are part of the preparation of the skin for collecting blood cultures anyway. You can choose an antiseptic that is more effective than others in clinical trials. We didn't even get into that here. You could limit the number of venipuncture attempts before preparing a second site. I'm sure we've all seen the people who have been, they go in, and, like they just can't get it before they go to something else. And then there are issues about requiring all cultures to be drawn by trained phlebotomists, which we saw was better also here. So one of the things to think about if you're, in the business of drawing blood cultures and listening to this is to figure out, like in your institution, how can you do things with a dedicated phlebotomy team, with peripheral draws, and if you're buying kits that cost more than the individual components, is this necessary, or can you save money by not actually doing that? And that will be things that are looked at during the A5 and A6 parts of the cycle. Okay, so you can ask questions by actually typing in questions for me. I'd be happy to answer some of those. And thank you very much for your attention today. Also, the slides are available in PDF form if you actually click the Content button on your screen and then go to Files. Thank you. If it's the first time you've heard about evidence-based medicine reviews, it is a mind blower. So I can see where you may not be able to formulate questions. To be honest with you, I had to hear it probably 5 or 6 times before it started to make sense to me. But I do admire what the CDC has done for its robustness and transparency. Okay, so if there are no questions, I thank you for your attention, and thank you for joining this webinar. Thank you.